I'm Dr. Sandra McAllis, and I'm here to talk to you today about research that we completed a couple years ago, focused on the impacts of flooding events on mental health in New Brunswick. And I'm a research associate affiliated with DataNB. So just the common acknowledgement slides for our data and funding. So this project was uh, funded through the Department of Environment and Local Government and supported through the Climate Change Fund, as well as funding through the MSSU, which is the Maritime Sports Support Unit that's funded through a variety of funding sources as detailed here. And this project uses several data sources that are accessible on our data platform at DataNB that are available for use, but it also included additional project-specific data that we were able to access for the purposes of this project that we received from the Department of Justice and Public Safety through the Department of Environment. So this, as I mentioned, is completed work that we completed a couple years ago, and so we have a published report on our website that you can access. So just to put some context before we get into what we did and what we found. So the bit of the background. So floods are actually suggested to be the most frequent and expensive natural disaster in Canada. And this frequency is only expected to increase with anticipated changes due to climate change. We're expected to have more and more intense floods. And New Brunswick is known to have frequent flooding, and so this is a concern for our population. And it's particularly concerning because of the mental health effects and the the negative effects on mental health that have been reported in previous research, including research here done in New Brunswick that has explored sort of the qualitative experiences of people who have been experienced flooding in New Brunswick. So there's clear evidence to support this outcome, but the previous studies were small. They used selected samples. So, for example, identifying people after a flood event. So, who's willing to participate in, who's not. So, oftentimes the results in some of these studies can be confounded. So, the data that we have provides another way to look at this similar problem. So in New Brunswick, we have quite a bit of experience with extreme flooding events. We looked at data over the last 15 years, and many times these were reoccurring in the same communities. Some of the data that we were able to put together characterize how many floods individuals living in the province were exposed to, and some were exposed to quite a number. So this is something that's important to consider as well in the research. And so, as I mentioned, the research here in New Brunswick was really limited to qualitative findings, and we wanted to identify evidence from quantitative data as well. And so that's exactly what we did. So our objectives were threefold. We were interested in characterizing who in the population is impacted by flooding using various demographic and socioeconomic and health-related characteristics. We were interested in determining which mental health outcomes were negatively affected, expecting that mental health would be negatively affected in folks who were exposed to flooding. And we were also interested in identifying among people who experience mental health outcomes or negative mental health outcomes, what subpopulation subgroups were most vulnerable. So who's more likely to have these experiences, and that would lead us to understand who, oh, I don't know what happened. Um, I'll just get back to um, who would be more in need of prevention targeting for future flooding or in the response period as well. So this was our approach. We considered 7 floods I mentioned over the 15 years. So we used various data to capture who was exposed to flooding. So we used data from Government of Canada, as well as I mentioned, Department of Justice and Public Safety. This helped us to identify who or where in the province was flooded. The image here is just showing what areas of the province were flooded, and these are maps that were created by Government of Canada, who works, I think, with EMO in the province when there is a flood because they have the resources and capacity to generate these types of images to support decision making. And so this helped us to identify where we map these areas to Statistics Canada dissemination areas, which will then allow us to link with our Medicare data. So the Medicare data is data that comes from the Department of Health, and we use that to develop a population-based study. So everyone in New Brunswick with a Medicare card is included in the Medicare data. And so we identified people who were in the Medicare data and living in areas that were in these purple areas as is in the image. And we identified people who were in New Brunswick pre and post that flooding event for 1 year. We were interested in looking at outcomes and longer term outcomes. Previous research had focused more on sort of shorter term outcomes, say, for example, 3 months. And we were interested in looking at that full year. And we wanted to get a picture of their pre-experience to have a sense of what their mental health outcomes would have looked like to be able to adjust for that and understand the experiences of people who had pre-existing mental health conditions. And we put all this data together, and then we used pretty complex statistical analysis to control for various factors, including area, pre-flooding mental health, as I just mentioned, as well as various health, socioeconomic, and demographic factors. So we looked at mental illness outcomes, but we also looked at alternate outcomes, knowing that our data may have some limitations in the ability to identify folks who are experiencing mental illness. And so we wanted to maybe just to describe the experience of people who had experienced flooding in all other outcomes that we could describe. So the mental illness outcomes that we looked at were health service use for mental illness, as well as for specifically a mood and anxiety disorder. Mood and anxiety is, of course, included in mental illness, but mental illness includes a more broad range of disorders. The second mental illness outcome we looked at was mental illness was hospitalization for mental illness and for post-traumatic stress disorder. One of the important mental health outcomes in related to flooding is PTSD, and so that was something that we wanted to look at in our data. We only have that type of information at the hospitalization level, not at a lower level, so that of course limits the ability to identify people who are experiencing that outcome. Number 3 is a physician claim for a service code that's counseling and psychotherapy. This does not relate to any specific diagnosis, but just identifying the need for those types of services from a GP or an NP, for example. We also looked at or tried to look at death by suicide because there was some research that was somewhat inconsistent about the impact of flooding on the risk of suicide. So as I mentioned, given our system data and the potential limitations in access, we wanted to look at some alternate outcomes to see how the experiences of those folks compared to the general population. So we also looked at emergency department use. We just looked at any emergency department use because we don't really have very detailed information in the New Brunswick data. We looked at hospital use for physical illness. Number 2 on the mental illness side is hospital for mental illness. So it was just the other conditions that people were hospitalized for to understand what those experiences were. In addition to hospital and health data, we also looked at some other outcomes. We looked at children and youth. So youth, we looked at those who are in post-secondary education. And for children, we were interested in understanding the impacts on school attendance. There was some previous research on school attendance, but I think only one study. So there was sort of interest in understanding what that might impact the children who were exposed to flooding. So just getting right into our results, this is just giving a sense of the first objective was really to profile who is exposed in the population. Sorry, 1 second. So the first set of bars is related to the age demographic. So most of the population that was living in those exposed areas is within the 25 to 64-year-old age band, but that is a predominant population in our province. About 50% of the sample were married, about 50% were female. Most were living with other people, so their household composition included not just living alone, because that was an important variable for us to look at vulnerability of folks who lived alone, because that's an important risk factor for exposure to flooding. Residential instability was something we were interested in from a socioeconomic perspective. So we looked at that from that perspective, but we also defined a demographic variable that defined how many years someone was living at that address within the Medicare data. And we also looked at sort of community size. This is a variable that comes from Statistics Canada. And we found that about 60% live in small community sizes. With respect to health conditions, sorry, there's so much going on my screen, I can't see. Um, we looked at chronic conditions, and we found that about 20 to 25% of folks that were exposed to flooding had one chronic condition, whereas folks who a large proportion of those folks also had two or more conditions. So a large proportion of chronic disease burden, which can create additional vulnerability when exposed to flooding. For example, if trying to manage certain conditions require sanitary conditions. The flood year represents the number of people who were exposed within the different flood years. So you can see here that the flood years include 2008, 2005, 2008, 2012, 14, 15, 18, and 19. As you can probably remember, if you're living in Fredericton, I'm sure if you're living anywhere in the province, but 2018 was the back-to-back flooding year. So we wanted to represent folks who were exposed to both of those years because those years were years that represented a significant amount of property damage. And so we also were able to, using data that came from Department of Public Safety, define folks who were living in areas because we weren't able to identify individual level data for property damage, but we were able to link to an area level. So we kind of just defined a variable based on whether there was property damage in your neighborhood, representing a higher degree of flooding. So the distribution of the population gave us an understanding of who was exposed to flooding in the population. We did find important differences between when we looked at between the groups that we defined as exposed and the groups that we defined as unexposed. And I'm just seeing if I can move this over. And so I had mentioned residential instability, that we defined it using a variable about how long someone's been living at their resident using the Medicare data. And that is one of the variables that StatsCan includes in their CIMD, which is the Canadian Index for Multiple Deprivation. And that index includes four subscales, and I've shown two here. And the two here are what show that there's a difference between the exposed and the unexposed population. What we did find was that the exposed population tended to be in the lowest, so the lowest quintile for situational vulnerability, the lowest quintile for residential instability, and they were among in living in areas that had higher income. So this represented to us that folks who were exposed differed from the general population. The exposed population seemed to be less vulnerable with respect to socioeconomic types of characteristics, which may make sense because property on the water is more expensive, tends to be more expensive, depending, of course, where it is. And so that might be what's being reflected in this data. So these are important factors for us to understand who is exposed and also to understand the differences between the groups because we were interested in understanding the impacts of flooding on mental health, which requires the need to adjust for these types of things because we want the groups to be comparable. So what did we see in the mental health outcomes among these populations? So we looked at changes in mental health outcomes pre and post flooding. So overall, the prevalences were quite similar. The bars look very different here, just because they're in a very narrow range. But overall, it was quite similar. But yes, yes means that folks had a mental health record before. So that's either a health service record or a hospital record for any type of mental illness. It was about 6.8%, a little bit higher at 6.9%. Had a mental illness record pre and not post. Perhaps their post was mental health service through a type of care that we are not capturing in our data. That's certainly possible. Um, uh, when we look at the group that had no, but then post had yes, and again, we only looked at 1 year pre, so they may have had records prior to that year, but we find that that's about 6.3% of the population. So this just was also sort of a way to describe what was happening in the population. And the rest who are not amongst these three bars is, of course, the group that's no. So they had no records in the pre or post period. So how did this change over time? So this is the individual mental health outcomes that we looked at. So I described mental health service, so that's physician and or hospital for mental illness, and then specifically for mood and anxiety. And those are the highest bars. Those are the most common or most prevalent. And certainly we see that the rates are increasing pre and post. So just under 14% pre had a mental health service for mental illness, whereas it's just over 14% post. If we were only to look at exposed, that might suggest that these are increasing, but in fact, when we looked at the unexposed group, those people who are outside of those purple areas that I had shown in that figure, that is very similar. Actually, the rate is actually higher in that group. But that's because this is not controlled for those factors that I mentioned. So socioeconomic factors and income, or those factors that I mentioned, as well as income, are really important to mental health outcomes. Those are important confounders to consider. Well, service or physician services for counseling was relatively stable, but also increased and a little bit higher in the unexposed population. Hospitalization, as expected, were very rare. Hospitalization for PTSD was just very, very rare. Like we couldn't really do much with it. So we've described it here, but our models were limited. The other outcome that is not here that just wouldn't fit on the bars because it's just so rare is the suicide, thankfully. But that was also something that we weren't able to really explore further in any of our modeling because the modeling that we needed for the rest of the project didn't really support it because of the small counts. So in future work, it would make sense for us to use a different approach to look at that in an appropriate way. So kind of alluded to some of the percentages in the previous slide, but what we found is among the exposed population, 14.2% had a need for mental health service in the year after flooding. And what we found was actually when we controlled for those factors that were different, so I'll just move all this stuff. Um, the exposed population was 9% more likely to have a mental health service record for mental illness, and they were 7% more likely to have a health service for mood and anxiety. So this just suggests that among the need for mental health service use in that year post flooding, it's really predominantly related to mood and anxiety disorders. Health service use driven by physician service, the counseling and psychotherapy use were, or sorry, oh, sorry, I misread this. The health service use of that of all that mental illness of that 14% was very driven by physician service use. So folks accessing GP services for mental mood and anxiety disorders, for example, because the rates of hospitalization for these types of illnesses was very low. Um, and most of the health service was for diagnostic reasons because the impacts due to that non-specific service code were quite minimal. So the impacts from flooding were very much driven by very much predicting a need for mental health service use. And again, that service use was in the community mainly. How did this look for alternative outcomes? So about 30% of people in the exposed group had needed needed to use the ED in that year post. We didn't look at sort of time of ED, but that's certainly something we could look at in more work. We looked at ED in older adults. Actually, we looked at all these things in older adults because we were wanting to understand, okay, well, this is the whole population, but what does this look like in, maybe a more vulnerable population? And if we were needing to understand the population of older adults, is there a way that we can target them better? So older adults are more likely than the general population to use the emergency department in that year. They are also more likely to use the hospital. Again, this is hospital use for not for mental illness. So if there's any mental illness record, that's not included here. And the exposed population or youth in the exposed population, about 15% withdrew from post-secondary education in the year after flooding. So we looked at everyone who was enrolled pre-flooding, and then we looked at whether they were still enrolled after the flooding, and when they should have still been enrolled, for example, and we define that as a withdrawal. So about 15% of folks withdrew. And so when we looked at that controlling for the differences in the populations who are exposed and not exposed, what we found that was flood exposed populations were 11% more likely to use the emergency department, and youth were 8% more likely to withdraw from post-secondary education. So as I mentioned, we looked at the whole population and then we looked at subgroups of the population to understand whether, this increase was driven by a particular subgroup, or were there particular subgroups that maybe had a really high rates of mental health service use, and maybe these are areas that we could focus on. So the average impacts really provide impact really at that population level. And so are given as sort of an average. And so when we look at population subgroups, we're looking at a stratified impacts, and this really helps us to identify who is more vulnerable. So not everyone is equally vulnerable. So we want to understand, how do we better target mitigation strategies, but also response strategies when a flood occurs. So we know that generally there's certain characteristics of folks that make them more vulnerable to mental health outcomes. So for example, females are more likely to have mental health, higher rates of mental health outcomes. But we wondered if that differed when someone was exposed to flooding. Does that change? Does that difference change between sex when we have a flooding exposure? And so, do we need to focus on populations? And so, the next two slides really focus on those subgroups. So the vulnerable subgroups that we identified that were particularly vulnerable, we looked at quite a large number of them. The ones that I showed in the original slides describing the populations. But we really found that people who had more mental health service records or higher rates of mental health service were those who experienced fewer floods than those who experienced more floods, which was kind of interesting because we thought, well, maybe they're more experienced, or maybe our data is just capturing folks who haven't yet accessed mental health service and need a physician and a hospital versus maybe having some type of community care, and folks who are further along in their flooding experience, I guess. We did find that there was higher mental health need among those who were exposed back to back. So that 2018 flood, if someone had a flood damage in their area, that was also a predictor of mental health, greater predictor of mental health service need. One of the strongest predictors from the literature of mental health has been suggested to be the height of the water in your living room, which is kind of interesting, and we don't have that data, so obviously we couldn't get that. We found children and youth to be particularly vulnerable as well. They had higher rates and higher than we would have expected because we know children and youth do have higher rates. And since this project, we had some summer students who dug in to the characteristics of children and youth who are more vulnerable. People who were there for a shorter duration were found to be more vulnerable. So that also gets at that community resiliency piece, which is something that was identified through that qualitative work that it mentioned that was done in New Brunswick as being really important. So that cohesion, and so maybe those connections are also not established with a shorter address duration. Interestingly, I mentioned the differences between the population, so we controlled for those things. But when we control for those things, we still find kind of interesting differences. So, who's more vulnerable? We would, of course, expect people who have more economic dependency or more situational vulnerability, greater socioeconomic vulnerability to have more impacts related to flooding. Flooding, damage is very expensive, and it could cause a lot of additional costs that are hard to absorb. But we also found that the higher need for mental health service among those who were more socioeconomically advantaged. So those who had higher economic dependency had more mental health service use. And one of the other things that comes from the literature, an important contributor to need for mental health service is insurance problems related to flooding. And I guess maybe when you have more things, you may have more of those types of instances. So this may be a proxy for some of those findings that have been identified previously. We also found that there was more mental health illness in areas that had less ethnocultural diversity. But we also find in other work that we've done that folks who are newcomers or have immigrant status are less likely to access services for mental illness. So not sure if this is a cultural and system factor or if it's a true vulnerability. We had many different subgroups when we looked at the different types of alternate outcomes, just reiterating the ones that we had with respect to mental illness. Oops. But also with respect to the other outcomes, similarly finding some commonalities. Fewer floods again appears with the emergency department use, flood damage in the area, socioeconomic related characteristics. For emergency department use, we also found that older adults who lived alone were more likely to attend the emergency in the year after. Again, we didn't look at the reasons for and frequency of when, but that's something that could be certainly explored. Hospital service use, adults and older adults were more likely to use the hospital following flooding. So this we worth looking into as well. Like, why are they being more likely to be admitted? Is it things that are related to the flooding or consequences from not being able to care for themselves related to maybe a chronic condition, which is also more likely? I thought that maybe folks with chronic conditions might have different mechanisms of getting into the hospital versus the emergency room. So that might be some of the differences that we're seeing there as well, multimorbidity, as well as folks who had least situational vulnerability. So that's people who are better off or in areas that are better off, I guess, with respect to the variables that are considered in here. And then the last outcome that we looked at was, as I mentioned, youth who are in post-secondary education. And what we found there was those who had experienced more floods were more likely withdraw from post-secondary. Those who lived with others, we're not quite sure about this because we know that youth don't necessarily change their addresses. So we're not quite sure about where they're living specifically, given the data that we have is focused on Medicare and that has limitations, of course, with this population. And we also found that those who lived in areas with least ethnocultural diversity were also more likely to withdraw. So I guess just bringing this all together, this really was sort of a first look at the population impacts of flooding in a higher risk population groups. This is, there's not much research in the area. There's a few studies done in Canada, and so this is really a sort of an important contribution and really an important contribution to our partners at the Department of Environment who commissioned this work, and we're really interested in understanding the populations exposed and the specific vulnerabilities to help guide sort of climate change and health adaptation planning. So the results really help to support those previous studies. The research that we're doing is really at the population level, but a lot of the other studies that have looked at this are really able to get into much more of the experiences or detailed information because they're using interviews or surveys to gather this information. And so our results certainly corroborate those findings as well as provide some additional insights that might not be able to be looked at in other types of studies or might now be able to be looked into more deeply in specific settings. There's Um, there's some work that's done in, I think it's Calgary, where they look at prenatal exposure to flooding and impacts on pregnancy. We didn't look at that, but that's certainly something that our data could help to support and identify as well. So additional pieces. And so it really adds to this limited evidence on impacts of flooding on health service. As I mentioned, most of the research is shorter term. So, a few months in the term following flooding, we we would be able to also look at sort of that frequency of when, but we, for the purposes of our study, decided to look at 1 year pre and post. So it's really a first look and starting to give a nice understanding of some of the experiences and population vulnerabilities. And so we particularly highlighted youth as a vulnerable group, given the estimates that we found being higher in magnitude for this population as well. They alone as an age group, but then as we found, one of the consequences may be withdrawal from post-secondary education, but that may just be one of the things that may be able to be related to the flooding exposure. So just to end off with some strengths and weaknesses. So strengths, of course, as I mentioned, we have this population-based sampling. We use the Medicare registry. So we include everyone in the province over time. We can follow them longitudinally and be able to identify how many floods they were exposed to. So that was one of the factors we used as a vulnerability stratifier. So we were able to look at how that impacted their mental health and in weird ways. So that would be worthwhile to look into a little bit deeper as well. We use this longitudinal study design, which really helped us to identify who was still in the province, for example, and who would not obviously be experiencing the mental health outcomes. So we didn't have to follow folks over time. We could follow them data. And because we have this system level data, we're really able to inform on the system level impacts. But of course, that is also a potential limitation. As I mentioned, we can't really get that rich data, and we can't capture some data like private service data, for example. Other limitations, of course, there's always many when we're talking about research, and that's always why we aim to do more. But the defining of the exposed population, as I mentioned, we had to rely on some geographies that are less precise, and so having more precise address information or obscured address information that would allow us to get better exposure classification would certainly improve. We know that there's undercounting of outcomes, as I mentioned, just accessing different services or not accessing services at all, for example. We had issues with data availability, for example. Only certain floods included emergency room data, as that was available only more recently. And as I mentioned through the presentation, the study design wasn't really well suited for rare outcomes. So for PTSD in hospital, I mean, we didn't find an effect, but it was very underpowered, I would say. And then also for the purposes of suicide, which I think in the research is suggesting that there isn't an impact of flooding, but certainly worthwhile to confirm within our data as well. So as I mentioned, we did have some summer students who did work on some additional deeper dives into children and youth, and on other types of health service would also be an area that would be valuable to understand how, as I mentioned, related to the physical need for physical illness related hospitalizations. I also mentioned several times the need for maybe looking at shorter term follow-ups in this data, but maybe also longer term follow-ups. What we kind of experienced in our data was, and which would require more time to sort out, was just sort of the overlapping. So we include year after year. Most floods have occurred in the spring, so we have a full year. So this period of and the data setup just allows us to maybe look at longer periods as well. Mobility arising from flooding is certainly something that's interesting and important to sort of think about how that might impact and who it's impacting and how it's impacting them. And with the data that we have longitudinally, we would be able to also look at that and map that out and try to understand how those factors were changing over time in the time after flooding. And then putting all the effects, dollar signs on all these effects is understand the economic impacts related to flooding with some of the outcomes we've looked at, but also other outcomes that can be identified from our data are also another potential area of future research. And so I think I've said a lot. As I mentioned, we have a report that we have on our website. And so that's accessible. We have a lot of different information on there. And I'm open and welcome to any questions as well. So thank you.